prioritize 5 thematic areas that are listed here. Apart from the climate, environment, and health, we do have HIV, mortality, antimicrobial resistance, so different types of areas that we prioritize. So let me just show you how we actually operate in this National Health Observatory. So we use and we rely on data that already exists from different data sources, not only the Ministry of Health data, but data from different sectors, such as the climate, environment data, economy data, and also data coming from vital statistics, so the National Bureau of Statistics. And all this data actually converge to a platform within the Ministry of Health, which is the National Health Observatory. And we perform 2 types of analysis. So situation analysis and also modeling activities to actually predict the risks and impacts, the current one and the future one. And all the results of our analysis actually are translated into different types of analytical products that goes directly to the process of decision making. And actually, the products that we produce within the observatory are have been actually prioritized and also validated by our high-level board within the observatory, which is a multidisciplinary board that we have there. So I want to mention some of our main activities within the observatory. So we do have activities in terms of forecasts. So the one in terms of short-term forecast is the one that it builds on the WHO EWARS, in which we do triangulation analysis, combining environmental and climatic data from the Met Office with our surveillance and health data. And then we had the opportunity to actually predict with 10 weeks in advance a probability of an outbreak of a climate-sensitive diseases, and these can actually be translated in simple products such as epi-bulletins, also reports and infographics at the local level to improve the process of decision-making at the local level. And then we have long-term forecasting, in which we again work with the National Met Office, because we do have an agreement with them in terms of data sharing, and we are working with them annually to actually predict in terms of climate-sensitive diseases for the following rainy season. And what we do actually, it's combining, again, the data from our sector and the meteorological data based on mathematical models, and then we produce risk mapping so for the whole country, so national-wide. And these maps actually predicts the outbreak of an increase of cases of malaria and diarrheal diseases during the rainy season, which has the length of 6 months in Mozambique. And we have been using these risk maps. As you can see, we have been working since 2019 official, but actually we started in 2018. And these maps have been using to our process of developing our contingency plans for the following cyclonic and rainy season in Mozambique. I want also to mention some of activities that we are ongoing activities which we have and policy brief that we are developing now to using cost analysis to assess whether we can introduce testing for arboviruses in our national health system, at least in the districts prone to extreme weather events. We do have, at the moment, a report in which we are working on, which is a report documenting the impact in Mozambique of the past 10 years of the climate change, and including also the social determinants of health in this report. And all these products are to be delivered to the decision making. And I want also to mention how our data, or the data coming from the technical people and the scientists, are actually being used by the policymakers So one example is that we do have some advocacy activities. We have actually organized in 2017 our first conference on climate and health in Mozambique. And at the same time, we released the first report in which we actually established the relationship between malaria and diarrheal diseases in the country. And actually, our fundings were actually part of the intervention of the Mr. President of Mozambique in the World Malaria Report, in which we hosted in Mozambique back in the days in our country. But we do have other examples, such as the second conference that we held last year, 2023, also in terms of climate and health. And we joined a lot of scientists, national and international scientists in our country. And also we, sorry, Vincent. Yeah, I know. I just want to mention that after our conference that we held in 2023, we had the opportunity to find out that working in a multi-sector collaboration, it's a way forward for the climate and health. Since we now have established a group among partners and government members in which we are dealing with the issues in terms of climate change in settings of in which we are responding to emergencies related to climate disasters. And finally, I want also to mention that it's important that we have organized this year the first conference on cholera. So it's a transdisciplinary conference on cholera. It was the first one we organized in the country and I think in the world, if I'm not wrong. And this was very important because there was a lot of approaches in terms of dealing with cholera, but also in terms of how we can address cholera in terms of climate and health. So I'll stop here. I'll have some other things to share, but I'm available after this.
Time is our enemy. These people are loaded at the back, and they're also looking at me to say, he was telling me, if she is on my time, that's your problem. So I had to stand up. So you can ask as much questions as you want. That here will give you some more time, because I want to give time to you, right, to interact with our panelists. So let's welcome our last speaker, Dr. Ibrahim.
Mangwanani, or it's now, the time is almost Masikati Akanaka. Most of the people are looking at me, what does that mean? Because we are in Zimbabwe, and you should have to interact with the community, the local. And this is all about what I am going to talk about. Good morning, and thank you, Jack, for having me in this very important conference. So my name is Muhammad Ibrahim. I am working with the WHO, and I am leading the One Health in the WHO Ethiopia country office. I am also Sherpa program coordinator for Ethiopia, which is a tripartite program for WHO, FAO, and OIE former, now OHA. So I will start with my presentation, what is One Health, and does it really matter for climate change and impact on health? To look at this and answer, let us go to the One Health definition. By taking, there are various One Health definition, and there is no any standard definition for One Health. So just to look at the latest One Health definition by One Health high-level panel expert panel, by defining One Health as an integrated, unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. One Health approach is also recognizes the health of humans, domestic and wild animals, plants, and the wider environment, including ecosystem, are closely linked and interdependent. For WHO definition, the approach is to design and implement programs, policies, legislations, research, in which multiple sectors communicate and work together to achieve better public health outcomes. So in 2004, during the avian influenza, there was a conference in Manhattan, New York, where the Wildlife Conservation Society have organized it. And in that, if you look at, they do have about 12 principles. And it clearly shows that there is no one discipline or sector of society has enough knowledge and resources to prevent the emergence or resurgence of disease in today's globalized world. So I will take you to the global level as a quadripartite, that's WHO, FAO, UNEP, United Nations Environmental Programme, and WHA, World Organization for Animal Health. They come up with a joint action plan working together for health of humans, animals, plants, and the environment. This plan of action has about 6 action tracks. I will look at the action track number 6, which is integrating the environment into the One Health approach. So if you look at that, at the bottom of these, you can see to integrate environmental knowledge, data, and evidence into One Health decision-making. For coming to WHO Africa Regional Strategy for Health Security and Emergencies, which is embraced on One Health approach, it clearly recognizes the absence of integrated, comprehensive, all-hazard strategy to complement the implementation of IHR and IDSRS. So this strategy will urge member states to ensure multi-sectoral collaboration in the implementation of this strategy. There are various evidences, publications that you can look at it. One is the publication that we had in 2018 about climate change and One Health. And also there are climate, for example, International Federation for Red Cross climate change impacts on health in terms of, in case of Ethiopia, clearly shows that One Health approach is strengthening the ability of the community to detect, respond, and prevent disease threats and play a significant role in the preparing for future risks. So for Ethiopia, we have Health National Adaptation Plan that's revised now on June 2024. If we look at this, it has about 8 strategic objectives. The first strategic objective is talking about strengthening multi-sectoral collaboration for better climate and health governance and leadership. If you go to the targets, which are 18 in number, target number 1, it talks about the establishment of multi-sectoral climate and health coordination mechanism at national as well as subnational level. And the key interventions, which are 10 in number, the first talks about the strengthening of multi-sectoral, and also the 5th talks about facilitating interdisciplinary collaboration to tackle the multifaceted nature of the climate and health challenges. So as a WHO, what are we doing in Ethiopia when it comes to One Health? So just let me take you back to the history of One Health in Ethiopia. After the WHO joint external evaluation in 2016, it came up with a recommendation that we should have to have a One Health platform which coordinate all One Health related issues. So Ethiopian government established National One Health Steering Committee, where 4 ministries are the voting members: Minister of Health, Agriculture, Environment, and Wildlife Conservation Authority. Of course, there are non-voting members, including WHO. And the important thing in 2023 was when the Council of Ministries approved to establish National IHR and One Health Secretariat Office at EPHI, or Ethiopian Public Health Institute, with the regulation number 529 to 2023. So I don't want you to go, because of the time, in a detail, but just these are the key areas of support. If you need any explanation in a detail, we can have later on. And the key areas of supporting WHO is for the development of One Health strategic documents, One key is the multisectoral coordination, the multisectoral zoonotic disease outbreak investigation guideline, because if you bring different multi-sectors and a multidisciplinary team, you should have to have a guideline how they should have to work. And that's a very difficult when it comes to the ground when we have outbreak investigation or response. Capacity building, especially looking at the One Health RRT. We have a general RRT, rapid response team, but we need One Health one each and every knowledge matter. And advocacy, now next week we will have a global One Health Day, and One Health sector and One Health cross-border coordination, and partnership, and mainly the One Health resource mobilization. And Ethiopia had the opportunity to receive the pandemic fund. And we have also One Health policy that we are working on it. So I have finished my presentation. This is the overall snapshot of what we are doing. The first top left is the pandemic fund inauguration on January 2024, where the World Bank and the pandemic secretariat team was in Addis Ababa. And also below that, we have One Health RRT training that we have conducted. And the top right and the Ethiopia, Kenya, and the Somalia One Health platform come together, learn each other, and collaborate each other. And of course, we have One Health Swiss Partners workshop that we have done. In conclusion, One Health approach to climate change adaptation may significantly contribute to food security, environmental sanitation, and steps towards regional and global integrated syndromic surveillance and response.
Maybe this. Okay. We can just take it down. Okay, so I think in the interest of time, because my panelists, they ate on your time, I will not start with them. I'll start with you in the floor. For sure, I know you have burning questions. You might have not questions, but comments, or maybe also some insights, some best practices, your experiences. This is the right time to show us or to tell us. So we'll allow for a few questions. Indicate by raising up your hands. To all or to any of the panelists, I have 2, 3. You guys, I don't think I'll give you time. I think about how many? 4. 1, 2, 3. Let's maintain them at 4. Yeah. So, yeah. Okay. Is there a roving mic? So we can use this one. So you keep this one there. Okay. Can you help me up to? Yeah, this.
Thank you, Chair, and thank you, the panelists, also for all the excellent presentations. My question is directed to Dr. Marufo at INS. I just wanted to understand how the INS is incorporating research and other scientific data into the into your model that you've laid out for forecasting, and how that is informing it, and how successful has that been so far? Thanks.
Okay, thank you very much, and thanks to all the panelists for the excellent presentations. My name is Charlotte Mbu. I am from the Geneva Learning Foundation, but I'm based in Cameroon. And my question is to Dr. Charles. In terms of integrated environmental surveillance, I just wanted to find out, how do we practically integrate environmental surveillance into existing event-based surveillance systems that involve communities? You know, because they have to identify signals that they can understand in the language that they actually get. And usually we hear communities say,
in my country that what is done for us without us is against us. So how do we practically make them involved in this? Thank you.
Okay, there are other two questions on the side.
Yeah, thank you very much. Much more of a political question. So maybe, Charles, you are the EU. Maybe you can. I wonder, every ministry in every country aptly responds to the national security apparatus. I've also seen countries that take the approach of National Health Security Office under the presidency. So politically and structurally, do you think it's a way to go? Or we still stick to the current arrangement of trying to massage everybody and keep on moving on? So it's to Charles, because you are with the OAU, but it's open to anybody who has experience in this.
I forgot that you say your name, so panelists, they know who they're talking to. I forgot, sorry. You need your name. Hussein. Rudolph from Ghana. And then the ladies, I think she said her name. Can go ahead, Prof.
Hello, I'm Brit Nackstad, Prof and Head of Pediatrics at the University of Botswana, and a clinician, so I'm very close to the patients and see the children and neonates when they come in dehydrated and malnutritioned after heat waves and so on. And also the crop is suffering from rural districts, so malnutrition is a problem that I see very clearly. So my question is, you all talked about the complex mechanisms leading to the changed climate-sensitive infections. So what about malnutrition and dehydration? Are these data that you show us, are they connected to malnutrition, weight loss, dehydration, or is it the vector or the infectious bug itself that leads to increased rates of these climate-sensitive infections? I would guess it's a combined thing, but I'm asking you your opinion. Yeah.
All right. I think that question goes to all of you. All right. I'll start with, you, Dr. Marufu.
Okay. Yeah, it's working, I think. Thank you, everyone, for the interest in this panel discussion, and specifically thank you for the ones who addressed questions to us. Thank you, Hussein, for your question in terms of how we actually integrate the research or the scientific research in the National Health Observatory. Actually, the research that we are conducting through the observatory, it's only the one use, the secondary data. If we want to generate data through the observatory, it's just a matter of recommending to generate. So we oversee a gap of knowledge through the observatory, and then we recommend the National Institute of Health or the boards that dealing with research so that they can actually produce the data to provide the evidence to the Minister of Health. This is how we work in terms of the National Health Observatory. So in terms of malnutrition, I think it's a very interesting question. Within the observatory, we are not doing a lot in terms of malnutrition, unfortunately, but in this current report that we are working on, we are trying to do some linkage of the malnutrition, chronic one and severe, the ones that we are seeing at the health facilities, and the linkage between the climate variables, and also how we can see in terms of once we eat it by an extreme weather events. But malnutrition is some sort of a chronic process. It's not like acute in most of the times. But we do have some data, interesting data coming in this report that we will be releasing by the end of the year. And you are quite right. So it's vicious cycle of malnutrition and infections because of the lack of the immune system. So it's depressed, and then you have malnutrition and infectious diseases. But it's tricky to actually understand the linkage between the climate-sensitive diseases and the malnutrition. Thank you.
You have two questions, and then the third one.
Okay.
Maybe we can do the two, so we can allow the panelists to take the generic one.
Okay. So I take the first one on how we link environmental surveillance with conventional surveillance, if I got you correctly, Charlotte. Yeah. So basically, there are various ways to do this, and I believe involves is where the communities stay, and we need to always interact with the communities in several ways. First, in programming of our surveillance systems, just like very many other health programming, but also in implementation. So one key thing we've tried to drive, especially from the Africa CDC perspective, is the integration of community health workers in the environmental surveillance system. And of course, most of those community health workers are indigenous to the communities. And that was where I talked about mapping. So when you map and you get hotspots of where these climate-sensitive diseases are prevalent, and then also you map based on the climate change determinants, then you can do that linkage at the community level through the community health workers whose capacity you build on both ends. That's one. But we also do sentinel surveillance, especially we do wastewater surveillance in the environment. So we see there are sentinel sites that are selected based on specific criteria. And then when you do those surveillance, we also develop interoperable data. So you try at the data points, we try to link health operational data with the environmental health surveillance data. Either because in some countries, environmental health is well domiciled with the Ministry of Environment. But when we have a very functional One Health approach, One Health coordination body, then you are able to operate their data, and you can link and make analysis from either of those ministries. And that is why coordination is critical to doing this. Then lastly, of course, I think we have researchers here, and I was happy with one presentation that looked at indigenous practices and how to create innovations around those. I think it's also good to get community perspective to a lot of what we do in health programming. And that is where the policymakers and the researchers need to interact, okay? So that those researches are tailored to what we help to inform appropriate policies. And we deal with the community, extract from them what the practices are. Some of the practices are very positive, and we can actually innovate around those practices. So those are some of the things I can highlight for now. And on the political question, I think, well, I can't really say why we have the chief security apparatus with the head of government. But you do know that the president in all countries is the commander-in-chief. And one of the overarching role of every government is provide security for its citizen. And I think that is why the chief security advisor sits in those places. But ordinarily, like when I did disaster risk management, we have NEMA, which coordinates for emergencies. And those report directly to the chief security advisors. So there is supposed to be a routine pathway, okay, for interactions with the government of the day. Then another reason is that for security issues, you need quick decisions, okay? And so I think domesticating that portfolio in the presidency is so that you can get prompt decisions when needed, okay, to be able to drive action. Those are some of the highlights. So I think for the other one, I will just turn it over to my colleague.
Yeah, I think for the last question, Dr. Nat Kutunda, and you can start.
Okay. Hello. It's fine? You can hear me? Okay. So I'll first add on to the question on integration and community involvement, especially in surveillance. I think part of the results which I didn't show, there was some mention of phone-based data form that is used by community health workers. And I think this example is from Kenya. But I think there are also many other examples elsewhere that are being used to collect data on climate information, but also into health. So this form was developed by an NGO or supported by an international agency, and they are working a bit parallel with the meteorological department, but they get the data and they are working with the community in that way. So I'm sure there are many other examples. We just don't know where to begin, and we're not sharing enough, but there are many ways of working with the community on this. The question on malnutrition, I find it actually to be a chicken and egg, because in most health facilities, and my work dates back to working with health facilities and systems, I remember us having health workers having to take nutritional assessments of their patients, assess and see where they lie on red, yellow, green, and then try to probe within the community what are the conditions that are surrounding that. That is one way. The other way, it's an indirect impact of climate change via weather conditions and let's say droughts and something like that. If you're predicting that, then you know that the health facilities are going to come up with people who are a bit, wanting in that. And like she said, it's a curve, it's a line. So you start to get to them when it is still early, or maybe it is late, and then you put them on supplementation. But I guess that in terms of categorizing it as a climate-sensitive disease, maybe a condition, not a disease. Yeah. We shouldn't say it can be categorized as a disease, but a condition, and then we can manage that. But it's two-way. It can either be from climate impacts, but it can also be from other factors. Thanks.
Thank you so much. Maybe I can have two more questions, comments, or some insights from other government. I have two at the back. Any other? I've got 7 minutes left. I think there are two questions. Two hands I'm seeing at the back. Yeah. There's no microphone? Oh, there is.
Okay.
You can say your name,
Yeah,
organization.
thank you very much. My name is Mauli Jojomenyu. I'm at the School of Public Health at the University of Ghana. And I think I would like to congratulate Mozambique for establishing this observatory. I think they've broken the glass ceiling as far as I am concerned, and we may all have to learn from them. But I have two simple questions. The first one is, where is this observatory housed? Is it a government institution, or is with an university, with a university? And the second thing is, as end users of this data of climate and health, how do you ensure that all those missing values that you see, the zeros in the data, you're not sure whether the data wasn't collected or is actually zero? How do you ensure that this is taken care of? Thank you.
Okay, my name is Gift Masengwe. I'm a senior research fellow at the Zimbabwe Open University in the Office of the Vice Chancellor. I'm also a postdoctoral fellow at the University of Free State in South Africa.
Can you speak aloud, or the microphone? We can't hear you from.
Oh, Gift Masengwe. I'm a senior research fellow at the Zimbabwe Open University. And I'm also a postdoctoral fellow at the University of Free State. I am in the field of religion. So whenever people are talking about diseases, I have different questions from the questions that we are answering. Because my question is, are diseases not part of the ecosystem? And if they are part of the ecosystem, how is it different that these diseases have caused suffering in the past, and how much change has climate change increased the suffering of people? And also, we also have some notions from religions where people are saying there is someone who is breeding mosquitoes, someone who is breeding these pathogens, and they are going to spread them in Southern Africa and to reduce the population. How do we look at that information? with what we have had in the past and what we are having now, so that we can be able to project this message properly. I think the presentations are very nice, but I see most of them are quite segmented. They focus on particular things, but they don't answer the big questions. That is my contribution.
Thank you. So I think that's a generic question. Let's take the last one at the back. Oh, no more questions. I don't have much time. Make your questions short.
Okay, so
Yeah.
good afternoon, and my name is Dr. Samuel Aliu. I work with eHealth Africa from Nigeria. I think my question goes to Mohammed, and for that presentation, and it's interesting to see the support WHO is giving to Ethiopia in terms of the One Health approach. And of course, we need to acknowledge the fact that we live in an interconnected world, and now with human activities, increasing, we are beginning to see that there are high levels of deforestation, intensification in livestock farming, antimicrobial, misuse and overuse. All of these are, contributing to what we see in terms of the interaction of microorganisms at, the human, animal, and environmental interface. So my question is, how is WHO supporting Ethiopia in developing risk mitigation strategies to address those high-risk events or activities, at the level of this interface between human, animal, and environmental? Thank you.
Thank you. Then the last question, then I'll close for questions.
Thank you so much. This has been a very interesting discussion. I'd like to just quickly go back to the issue on
your name, please. And
apologies. I just saw I have 1 minute, so rush. Judy Omumbo. I'm from Kenya, and I work with the Science for Africa Foundation. So it's around the issue of biosecurity and the fact that it's actually placed in the Office of Security, which I just wonder whether it takes away the ability of the health sector to look at things. I think biosecurity is very much seen as an agenda that is held by people with dubious intention, nations with dubious intention, which means that when we come from a continent like Africa that is very biodiverse, and this is where pathogens tend to emerge, the health sector is not developing the resilience to stand, for what's required to maintain our biosecurity. Things like the health sector needs to make sure that there's capacity built for surge. That gets left out because this is handled by military people. So I wonder if there's something that the health sector can do so that we can work a little bit better or own that agenda for biosecurity.
Thank you. I think that's a general question as well. So I'll start with Dr. Maruf for just a minute, and then what was the specific one? Mohammed. Oh, Dr. Mohammed, and then you can start with is it third question or the last one? The third question. The last one. Both. Okay, all right.
Okay. Thank you once again for the questions. So it's actually an interesting question that I didn't make it clear during the presentation. So this platform was actually at first established to be a virtual platform. It states in our documents that the National Health Observatory, it's a virtual platform to assess the situation of the health population in Mozambique. But of course, in terms of operationalization, it's difficult to work in our countries as a virtual platform. So the technical secretariat of this observatory, it sits actually in the National Health Institute of Health, so the National Public Health Institute of Mozambique, in which we work, I'm just answer the second question, has technical and multi-institutional, multidisciplinary working groups with different types of expertise. So the data that we are collecting from the different sectors, we work with the sectors to clean the data and analyze the data with them. So I think it's a way to actually avoid missing data and a lot of errors during our analysis. So I will let the others to answer the general question.
So let's start with Dr. Mohammed. Just 1 minute.
Okay, thank you so much for the nice questions. I will try to connect the two about the disruption of natural habitat, the ecosystem. Just to point out one point in that regarding, if you disrupt any natural habitat, there are many opportunities, high opportunities that microbes can increase the virulence. And there are many microbes which are normal at peacetime, but when their habitats are disrupted, it will change into pathogenic. And so for that reason, again, that's why I am advocating for One Health, not to look at in a single window, just we should have to look at holistic approach. Regarding colleague from Nigeria, risk mitigation strategy when it comes to One Health, as I have mentioned, One Health is a new, the concept is not a new actually, but nowadays because of the emerging and re-emerging infectious disease. Saying that if you look at the emerging and re-emerging infectious diseases, 75% of them are zoonotic, which means those diseases are animal origin. So lastly is now we are talking about Mpox, Marburg, Ebola, before COVID was the disaster one. So all these are zoonotic diseases. So because of the early stage of many countries, now they realize it and recognize that One Health approach is so important if you wanted to tackle the problems, the resurgence of these infectious diseases. We should have to adopt One Health. So what we did in Ethiopia, we are supporting WHO. As a WHO, we supported the government. And then that means we are closely working with the National One Health Steering Committee, where we create a platform, bringing different disciplinary sectors to talk to each other. So in 2019, the USCDC tool has been used to prioritize 5 zoonotic diseases: anthrax, brucellosis, rabies, and then 2 diseases that we don't have but as a prevention: Rift Valley fever and highly pathogenic avian influenza. These are the 5 prioritized zoonotic diseases, and for each has a strategic plans. So what we are exercising in terms of risk is using the quadripartite joint risk assessment operational tool. It's available, very useful operational tool where all sectors come together if you are dealing with the zoonotic diseases. I think that's all. Thank you.
Thank you. Then you can take the last 2, right? Or you're going to take the third one?
2.
The last 2. We can combine them. Then Dr. Charles will also, add.
Thank you, Chair. I'm going to respond to the question of the postdoc from Zimbabwe at the University of Free State. You are basically looking at what in epidemiology we call epidemiologic triad, where we have the host, the vector, and then the human being. And whether we can attribute climate change, for instance, for causing some of the increased prevalences in some of these diseases. I think there is a lot of literature, scientific literature, attributing climate change, for instance, to increasing malaria. In most of our countries, the highland areas used to be malaria-free zones. But because of warming up of these regions, especially highland areas in Kenya, in Uganda, we have malaria prevalent, epidemic prone in these regions. So we can clearly attribute climate change to these occurrences. I will come to the question of biosafety and why in some countries it is in security. Ministry of Security. Let me explain what it is in Uganda. It is under the Ministry of Health. We have the Public Health Emergency Operation Center. This is where this biosafety is housed. But this office works with the rest of the other sectors. Security, Ministry of Security, Internal Affairs, the immigration, all these are part and parcel of the core team working with on biosafety. And a few years, Uganda organized a big meeting for the whole global community on biosafety, and they were discussing these issues. So it's country, I think, country by country, but I feel it should be under Ministry of Health, because that's where the health ends. Thank you.
Thank you.
Okay, so if I may quickly add, for me, biosecurity and biosafety actually is multi-sectoral. If you also go across many countries, you see the agricultural sector have their own component of biosecurity and biosafety. The health sector has also an implement. But overarchingly, there's aspects of it that has to do with bioterrorism. And that is where it's critically important that that is domiciled with the presidency. But all of these feed into the security network. So at the level of controlling infectious diseases, the Ministry of Health, the Ministry of Environment, and the Ministry of Agriculture, which is what we're talking about, the One Health, have to articulate and then build capacities across board for them to be able to implement this. Then on the question on the interaction between climate change and infectious diseases, just to correct one thing, diseases are not part of the ecosystem, but agent-causing diseases are part of the ecosystem. And there is usually an equilibrium that sort of is maintained when things are normal. But in the presence of climate change, there is a disturbance, and that disturbance can either affect the human being, which is the host. It can even change your internal mechanism and make you more susceptible to diseases that you would have not ordinarily have. You might have some little plasmodium in your system. A little heat stress as a result of climate change can actually make you to calm down. So it can also affect the agent and make it more virulent, so it can cause more disease, or it can even proliferate. It can make the vector that carries the agent to breed more. So there are more mosquitoes, more bites, more people come down with malaria, and it's as a result of climate change. So climate change can change an environment. Like I talked in my presentation, 1 degree centigrade rise in temperature can make that environment become very conducive for the breeding of mosquitoes. Drainages that are not cleared and all of those. Or flooding can put water everywhere and then mosquitoes breed. So those are some of the linkages.
All right, so I'm already eating on people's lunch, so yeah, you can, yeah.
So quickly, I wanted to talk about the biosecurity. And I think all of us have one lens of what we are trying to do, and another lens sometimes we don't know. But there is an ethical and value disagreement lens in this kind of discussion. Bioterrorism depends on whose values are we looking at. If we are seeing someone breeding mosquitoes to kill the population, is that true, first of all? Are they doing it for that true cause? Or do they have another thing that they're looking at? So there is an issue of ethics, there is an issue of value disagreements, and we need to work together. Because however much we run away from people who are such and want to fight against them, unless you understand their values and what causes them to drive that, then we are going to kill each other, ever.
All right, thank you so much. We can clap hands for our panel, for our discussion. I hope that was very informative and interactive. There's something that we are learning. I was learning a lot from the questions, especially the questions that were coming. There's some new information that I also got today, and also the insights from the panelists. I think they got it, right? So we are going to break for lunch, and then we're going to come back again. We have 2 sessions that are going to continue in the same 2 rooms. We are going to have the intersectoral work for mitigation and adaptation in the other room. I forgot the name. Shija. And then we have building climate resilient health systems in this place. So please be here by at least 1:45 so that we start the sessions. Thank you so much. Enjoy your lunch. A group photo.
I'd love to have all of you come if you're able. It's just in the Mushero room. So I emailed a couple that I could find your emails, but some I couldn't find your emails. So please come afterwards. It's 5 o'clock.